Now, the topic that I was asked to speak on is CGM as an engine of precision insulin optimization. So, I haven't, per se looked at too many slides and graphs and data to show you, but just put down a lot of points that gives us things to look back on when we go home and use CGM on how we're going to use this technology and change our practice. Now, it's gone the day when we can think of doing anything without technology. We're connected to our phones, we're connected to our watches, we're monitoring our sleep. Of course, we use it for patient care. Where does CGM come in? Now, this is specific technology that helps to give us a whole range of uh, fluid values, interstitial fluid values of glucose levels, and we get this information that is changing constantly. So it's not just a one time reading or one reading every couple of days. This is a continuous measurement. And how does this help us? We use this data to then decide what therapy a patient needs, or if they're already on treatment, then what are we going to change? Is it the food? Is it the exercise? Is it the medication? So the question then comes is the technology enough, or is learning how to use the technology more important? I would say it's actually the latter. The technology has been around for a while. So, what are the broad aspects in which we can use CGM to change our practice or to change patient care? Now, optimizing insulin doses is one of those areas, or changing regimens is one of those areas where we use the CGM information. The real time values will help patients readjust their insulin dose. If they come back to us with these values, then we actually know if the patient is doing it right. And yes, we all know, we've known for a long time now that if you just do an A1C, it gives an average, it doesn't give you exact peaks and troughs. And the same thing is for SMBG as well. The other fact also is if you asked a patient to do an SMBG, let's say after a meal, and you may have told them check at 1 hour or 1.5 hours or 2 hours. Now, the glucose value may have spiked at 45 minutes. It may be normal at 1.5 hours post meal when the patient has checked, and the A1C is not at target. The patient then comes back to ask you what's wrong. So, we have to recognize that those traditional time points of glucose measurement with a capillary blood glucose value may not cover the 24-hour reading. So even between those time points that we ask patients to measure and come back, there could actually be spikes. Of course, there are hypos which go unnoticed. There could be surges due to hormone changes, which again are not picked up, and these are areas where CGM is going to help. So, what would it tell you if you had to change someone's insulin regimen? Now, if someone's connected to a pump or even pens and they're using the CGM device and getting the real time values, they would need to use that information to see if their basal dose is okay. Are there post meal spikes? Should we adjust a mealtime dose? Or is that actually fine? Is my fasting okay? No night hypos? My mealtime values post meals are okay, but maybe it's a snack which is causing an issue. Maybe some other pre meal value is spiking because of the mid meal snack. So, what exactly is the issue with the patient's diet, with the patient's routine? Is something you can identify. So, if the patient's on insulin, then yes, we adjust the insulin. But it patient's not on insulin, it may still be readjusting their food, their lifestyle, and their oral medication. Now, the traditional approach for many years was okay, we do the A1C, then we again monitor, then we check the A1C again. But looking at the A1C and historical data doesn't necessarily tell us how the patient is going to do in the next couple of weeks, because life changes, routines change, and a lot of things happen dynamically. Now, the advantage of CGM is that the patient uses the information immediately at that point of time and make changes which are continuous. So the key again comes in identifying individual variability. Now, not everyone needs the same rate if you're using a pump. If someone's on premic, you open any textbook that says you give 2/3 morning, 1/3 in the night, and then go back and see how many of your patients are on that. It'll probably be none, or maybe 1 out of every 100 patients who are in that fixed proportion of 2/3, 1/3. Okay, there will be people who require insulin of at different times of the day, different quantities. You might not know which time to give the insulin with. It need not necessarily be the morning meal. It could be lunch. Maybe that's the high carb meal. Maybe it's dinner. So, all of this information actually helps us. And then we individualize the food, sleep, and exercise. This again changes when there's illness, stress, hospitalization, travel, change in routine. Now, the other area where CGM could be helpful in making more individualized treatments is the alerts that come with CGM, because there could be alerts that come on your phone, alarms, and this helps a patient identify when he's likely to get into a hypo, which may be half an hour away. So you avoid the hypoglycemia and the rebound snacking and maybe the additional glucose intake. So maybe you just have a slightly smaller snack with a little less carb and then you avoid the hypo, or you reduce the basal rate. So this is for a pump. So you can actually intervene in time to prevent an acute complication. Or the other way around, it could tell you that maybe your sugars are likely going, it's trending higher and likely going to hit 200 to 250 in X amount of time. Maybe you've been sedentary at a desk for too long, you've had a meal, and then there's an alarm, and you get up and take a break and just walk around for 5-10 minutes and then come back and sit. So there could be a lot of things that an individual person can do by looking at even trends and alerts even before the actual event happens. But a lot of this again comes back to education and using this information for personalized lifestyle modification. And only then this information is going to be helpful. If a patient does not know how to interpret the CGM data and make these continuous changes, it is going to come back to you after 3 months with 3 months of CGM reports. It's actually quite pointless. So, this whole point of using a CGM is that there should be structured education that goes hand in hand, that teaches the patient and empowers the patient to understand what is high, low, and make changes to their life. Yes, there are people who use pumps, much lower in India, but CGMs can be paired with pumps. And if it's a closed loop pump, then that becomes much easier because the basal is just going on its own and an individual is actually just taking the bolus doses. And there, based on, again, the trends, the basal rates get adjusted and hypos absolutely stop, because once the sugars start falling a little bit closer to the hundreds, we could set a trigger and then the basal rate will come down. So how does this clinically affect our patients? We reduce the highs and the lows, so better glycemic control. We can use these metrics like TIR to assess glycemic control. But remember, if we think the precision comes from the data and using the CGM, we are actually wrong. We're far from that. The precision only comes in your ability to analyze the data, to see cause and effect relationship based on the patient's sleep, food, exercise, illness, medication. And you need to then teach the patient also how to make changes to their routine with that information. So the precision actually comes from our thinking. So the limitations of CGM is it only dumps the data on you. It doesn't tell you what to do with the data. So you need to optimize the medication. You need to still spend that 20 minutes with the patient and understand their lifestyle and the reasons for the individual variation. Of course, we all need to have a very, very good understanding of pharmacology to use the pharmacotherapeutics available. So this is one study which looked at what difference happens if someone is just put on CGM versus someone's put on CGM and taught what to do with CGM. And you can see here, there was, with the structured education, the A1C reduced by 1.3%, but just putting someone on CGM was 0.8%. And the TIR improved and went up to 63% from the baseline of 40s, and just putting the CGM, it was 44%. So just putting someone on CGM alone, because we have the technology available, is not going to be enough. So if we need to use CGM, we have to first learn about different devices. Which company, are they validated? I think we're going to have a talk on that coming up. When to use it, when not to use it, how to interpret the data, what are the normal ranges. Then understand the therapies, understand the individual variations for every single patient. teach them how to respond to alarms, and then teach them what we know, because they're not going to come back to us with the CGM every week or every 10 days. So they need to be able to do this on their own. So with that, I would actually end and say that CGM is useful, but it only gives you the data. What you're going to do with the data ultimately decides if this was a useful investment for your patient or not. With that, thank you.